Hi, I'm Dr. Danny Soares, and in this video segment, we're going to talk about the different types of facelifts available today.
Okay, so let's get to it. Facelift is a common name for the medical procedure known as a cervicofacial rhytidectomy. The words cervicofacial and rhytidectomy explain what the procedure does. Rhytidectomy comes from the words rhytid, meaning wrinkle, and the word ectomy, meaning the removal of. Cervicofacial merely means neck and face, so a cervicofacial rhytidectomy is the correction of facial and neck wrinkles. However, because different individuals can age at different rates, we have different facelifts available today. This is critical for patients to understand.
Some people think that all facelifts are the same, while if you actually search online, you may actually come out thinking that there's hundreds of different types of facelifts. In reality, there's only about a half a dozen of true surgical techniques employed in facelifting. And it's important to know the differences between each technique because the technique that would apply best to a 45-year-old face differs dramatically from the technique that would most likely work best in a 75-year-old face. Now, the reason why there are multiple types of facelifts available today is because the procedure has been performed for at least 100 years. And over that period of time, the procedure has evolved to achieve more natural results across all age groups. So in order to simplify the understanding of this topic, I have chosen to take the historical perspective, starting more than 100 years ago with the first facelift and gradually describing the evolution of the technique into modern times. Also, you will need to have some basic understanding of human facial anatomy as it pertains to facelifting. I have created a video summarizing the basic anatomy of the human face, which you can access in the link provided below.
The first facelift was performed more than 100 years ago in 1906 by Dr. Erich Lexer and first published as a procedure by Dr. Eugen Hollander in 1912. At that time, and for the next 70 years, the facelift was essentially a skin-only procedure. Initially, early facelift surgeons would simply remove ellipses of skin from the face and neck and then close them, thereby pulling on the skin, which would provide a short-lasting lift of the lower face and neck. Later, as surgeons realized that undermining a greater amount of skin would yield better results and reduce scarring, the classic skin lift was developed. The surgeon would lift the skin away from the underlying muscle, pull the skin, remove the excess skin, and then suture the skin edges back together. However, the skin-only lift left much to be desired because it did not provide long-lasting results, was prone to inadequate correction of facial aging, and still created noticeable scars due to increased skin tension.
Surgeons knew they needed something better, but the procedure remained essentially unchanged for more than half a century.
Then, in the 1970s, Dr. Tord Skoog, a Swedish surgeon, discovered that he could achieve longer-lasting and more natural-looking results by actually pulling on the muscle below the skin instead of simply lifting the skin. Upon further detailed anatomical dissection, two surgeons, Dr. Vladimir Mitz and Dr. Martin Pironi, thoroughly characterized this muscle layer in 1976, effectively labeling this muscular layer as the superficial musculoaponeurotic system, or SMAS, or SMAS for short. The SMAS is a thick fibrous layer that immerses all of the superficial muscles of facial expression. The SMAS is essentially a unified layer that allows the face to move in a way that actually creates facial expressions. The SMAS is the primary target of a facelift surgeon, allowing the surgeon to manipulate the face and correct the drooping of the tissues of the face because the SMAS is thick and is able to maintain tension.
From that point on, the facelift would evolve into multiple forms. Early on, because the goal had become now to tighten the SMAS, most of the differences between different types of facelifts related to how the SMAS was tightened or shortened.
Some surgeons would simply fold the SMAS upon itself, a procedure known as a SMAS plication. This limited technique is still often used today, especially in most mini facelifts, as it can be performed rather rapidly because no actual cutting or dissection of the muscle layer needs to be done.
In further attempts to enhance the longevity of SMAS facelifts, surgeons devised ever more aggressive types of SMAS work.
The SMAS imbrication was born out of a need to create a longer-lasting SMAS suspension. Here, the SMAS itself is undermined, lifted, and then overlapped in a diagonal vector and sutured in place, creating a more thorough suspension of lower face and neck. In an attempt to make the procedure quicker without compromising safety, an additional facelift method known as a lateral SMASectomy was developed by Dr. Dan Baker in 1994. In a SMASectomy, a strip of SMAS is removed in the lower face and neck, and the edges are sutured, creating a lift by shortening the SMAS layer directly. Now, these earlier SMAS facelift techniques, labeled as Skoog type Rhytidectomies, were quite capable of addressing the lower face and neck, but they did not address the aging of the cheek. This is in part why these earlier techniques also became known as Low-SMAS Rhytidectomies.
In addition, surgeons quickly began to notice that in patients with significant mid-facial aging, tightening the lower face would generate a very artificial-looking lateral sweep. And that was one of the impetus for surgeons to develop ever more aggressive types of facelifting that would address the mid-face as well.
The problem was the presence of two strong ligaments, the zygomatic retaining ligament and the mesenteric retaining ligament, which prevent the cheek from being mobilized upwards. These two ligaments could not be properly released during conventional Skoog type rhytidectomies, preventing the surgeon from applying a more vertical vector of lift to the face. In addition, these facelift techniques also failed miserably in correcting the nasolabial fold or laugh line, and this was because the SMAS was also strongly attached to the zygomaticus muscles. Something better was needed still. In the late 1980s, while surgeons were still debating on the best way to suspend the SMAS layer, two surgeons, Dr. Sam Hamra and Dr. Fritz Barton, were trying to figure out how to improve facelift results even further to correct the nasolabial fold and suspend the cheek vertically upwards. Their work led them each to a variation of the facelift that not only suspended the lower face, but also the mid-face, creating a more natural vector of lift and correction of the laugh line. Dr. Hamra's seminal work yielded the deep plane rhytidectomy, which remains a facelift standard to this day, while Dr. Barton advanced the High-SMAS rhytidectomy. These more advanced facelift techniques came to be known as extended SMAS facelifts due to the additional work needed to mobilize the mid-face. The deep plane facelift begins by still undermining the skin, but only a small amount. The SMAS is then cut and elevated as in a typical imbrication. However, the dissection is carried much farther, releasing the zygomatic and mesenteric ligaments and allowing the mid-face to be suspended when the SMAS is pulled in a diagonal vector. In addition, because the attachments of the cheek to the zygomaticus muscles are released, pulling on the SMAS flap now also helps directly correct the nasolabial fold. The High-SMAS facelift begins with a similar sequence of events. A narrow strip of skin is undermined, followed by a SMAS cut and a SMAS elevation all the way across the midface. However, the SMAS is then transected high and the SMAS is elevated directly upwards, producing a vertical, more natural vector of lift for the cheek. This is why the procedure is known as the High-SMAS facelift.
Since then, facelift techniques have been modified to include shorter incisions, varying degrees of neck work, and also to incorporate additional cosmetic procedures such as an upper blepharoplasty, brow lift, or even skin resurfacing. My personal favorite technique is actually a modification on the High-SMAS facelift known as a Lamellar High-SMAS, as described by Dr. Timothy Martin.
This technique is similar to the High-SMAS technique, but it involves a longer skin flap dissection. This allows the muscle to be suspended in a vertical vector, which is a more natural vector of lift, but the skin is pulled back, allowing for greater improvement of the nasolabial fold.
In addition to the different techniques relating to facelifting that we have reviewed in this video segment, there are also numerous techniques that apply to the neck. To find out more about those, please tune in to our next video segment here on Aesthetic Minutes. Thank you for watching.